I think they're the same now as they have been for a long time. It's kind of this age-old question, or this sort of balancing act between, trying to ensure that our empiric antibiotic therapy is tailored to the patient's risk, but also broad enough so that we don't have long delays in time to effective antimicrobial therapy that we know leads to increased mortality. And then on the flip side, especially from a stewardship perspective, we're trying to obviously limit the misuse and overuse of antibiotics, especially broad spectrum antibiotics. So we're kind of always walking this delicate kind of Goldilocks window between, not too much, not too little, just the right amount. So I think this will, it has been a challenge. It still is a challenge, and it'll be something that I think we're always challenged with, because there's just real, there's not a lot of middle ground there. So we're trying to squeeze it as much as we can. Yeah, I think it pretty much tracks with kind of the increasing rates of antimicrobial resistance, nationally and internationally across the world. So, I don't think they're really anything special per se. In fact, they're more often culture negative or have more susceptible organisms. But I think if we looked, it would trend with the antimicrobial resistance across the globe. I think stewardship in this setting, our job really in general is to optimize antimicrobial use. And especially, I think, as we mentioned the last question, I think this is an area that's perfect for it. And I think the two most impactful ways we could probably do that is through our knowledge of PK/PD and optimizing the way we use antimicrobials to maximize efficacy and minimize toxicity. And then obviously, I'm a big proponent of rapid diagnostics. And so I think rapid diagnostics are a huge tool in this setting, especially when combined with antimicrobial stewardship intervention, which I've demonstrated improvements in clinical outcomes, costs, kind of all the stuff we look for. So those are probably the two, I think, most important ways that stewardship can get involved in that setting. Yeah, I got to go back to rapid diagnostics here. I mean, I think there's, if you look at kind of all the antimicrobial stewardship interventions, or maybe clinical interventions in general, maybe with the exception of vaccines, the rapid diagnostics in conjunction with antimicrobial stewardship intervention, especially in patients with bloodstream infections, has been shown to decrease mortality significantly and decrease length of stay, costs, kind of all the metrics that we look for, both from a patient outcome standpoint and a stewardship metric standpoint. So I think, if you have limited resources like we all do from a stewardship perspective, and you have limited time, energy, and effort, I think you get the most bang for your buck in, putting it into something like a rapid diagnostic technology. And I think the data supports that. I actually really like this question. Now I'm the co-director of infectious disease and critical care kind of hybrid fellowship. And so, I have quite a bit more interaction with my critical care colleagues than I have been in the past. But I think, I took a look at the paper that you sent, and I think it's interesting. I think a lot of this discussion stems from that original Kumar paper, 7.6% increase in mortality for every hour delay in antimicrobial therapy. And a lot of people quote it like that and just stop there. And my trainees know that I always harp on them is that was from the onset of hypotension, which at the time we were using SIRS criteria, and hypotension wasn't even one of the 4 SIRS criteria. So certainly, I think everyone would agree that there's going to be impacts on mortality and a detriment on mortality in a patient who's hemodynamically unstable. And I think those, Q-SOFA does include hypotension now, but still, I think, rapid, timely, effective antimicrobial therapy is important in all patients, whether they have a serious infection or not. There's good data in C2I patients, stuff like that. But it's certainly going to be heightened in those patients who are already, in septic shock and hemodynamically unstable. Their mortality is already going to be significantly higher. So, if we had to prioritize, they probably take priority over just patients with sepsis and then on down from there. But I don't think, I don't know that they're completely separate entities. It's just a progression of one into the other. And so I think, again, from a stewardship perspective, especially if we have to prioritize, maybe who we're going to run a rapid diagnostic on, or who's going to, take our time from an intervention standpoint, obviously the septic shock patients are certainly the most vulnerable. Yeah, this is a great question too. And I think I might be a little alone here too, but I think, part of it comes with the territory, obviously, right? So I work at a predominantly uninsured, underinsured patient population. Our hospital is mostly made up of those patients. And so we've spent a lot of time thinking about CMS measures and what we're getting reimbursed for and stuff like that. And we found it to be actually a pretty valuable tool if used the right way and kind of applied the right way. for example, hospital-acquired C. diff, right? We don't get paid for that anymore, and so there's a lot of initiatives going into reducing hospital-acquired C. diff as we should. And so if we think about, let's say from a stewardship perspective, we want to curb our fluoroquinolone use for obvious reasons, and we've tried kind of other avenues of getting to that endpoint, but we never really had enough support, especially from higher up kind of C-suite administrative people. So if we could go to them and say, hey, we use the hospital-acquired C. diff, as a potential, hey, we could potentially reduce our hospital-acquired C. diff based on previously published data if we restrict the fluoroquinolone's use. And so that might not be your primary goal, but it's a way to kind of get those people's attention, and because that's what they have to care about: reimbursement, money, kind of compliance, all those sort of things. So I think it's just all about knowing your audience, kind of tailoring your message to who you're talking to, and understanding what things are driving them, and how they're making decisions. And I think CMS reimbursement could be a way to do that. Another thing we've kind of explored in the past in some of our previous rapid diagnostic papers is using like the CDC core elements, trying to work in rapid diagnostics into something like that, because again, they're sort of compliance type stuff, that regulatory stuff that those people kind of care about, maybe even more so than we do a lot of times, because we're obviously more in the clinical realm. So I actually think they can be a useful tool if you know how to employ them. I think, again, I guess I'm repeating myself, but it goes back to diagnostics. I mean, I think we all saw, for better or for worse, obviously the juice wasn't worth the squeeze there, but even as far as to the lay public saw, how important diagnostics are, and having rapid and most importantly accurate diagnostics, and enough of them, right? And so I think it was a big wake up call on, just how important our clin microlab is, how important diagnostics are, how important it is for clinicians on the clinical side to understand diagnostics to a certain level, how important that collaboration between our microlab and the clinical side is. I think it just really, at least for me, that was kind of one thing that jumped out at me, is it really highlighted that we still have a lot of work to do in this area, and improving those relationships and that kind of seamless transition between the lab and the microlab and our clinical practice folks. Yeah, I mean, again, I think diagnostics are the improvement. If you talk about trying to combine something that a pharmacist can do, along obviously in collaboration with the microlab, and then improving stewardship and patient outcomes, you'd be hard pressed to find one single intervention, in my opinion, that can do all that, right? Prior authorization and feedback or whatever, all that kind of stuff has been shown to help from a stewardship perspective, but really doesn't have a big impact on patient outcomes as you would expect. And so I think rapid diagnostics are a nice bridge between that, and kind of can hit all those angles. It can help curb, overuse and misuse of antimicrobials, but also improve, patient outcomes like mortality, and be cost effective at the same time. So I think, again, if you're in a resource limited setting, I think we all are, no matter what, right? And you only have so many bodies that can do these kind of interventions. I think you'd be hard pressed to find something else where it would be worth the return on investment that you get, like you do with rapid diagnostics.